Good morning. This morning I would like to talk to all of you about a subject that is really near and dear to my heart, which is making the NICU a safer place. So we're going to talk about general principles of safety, and we're also going to talk about 3 specific studies. And this should show people like yourselves who are in training what the possibilities are for improving safety within the NICU setting. I have nothing to disclose, no conflicts of interest at this time. So our objectives for the talk today will be to, first of all, give a general review of the history of safety initiatives in general, understanding the importance of benchmarking our data and the use of process control and how that can cause rapid cycle improvements in safety measures. And lastly, we'll talk about 3 studies that aim to improve safety within the NICU setting itself. So just think about safety in general. If we were to, for example, propose that there would be a 1% error in something that we do in medicine, which is not at all unusual. In fact, in many instances, there's more than a percent error that we accept. But would we accept that same rate of error in other industries? For example, in the airline industry, if we accepted a 1% error, we would be talking about 3 major plane crashes every day. If we're talking about the U.S. Postal Service and we accepted a 1% error, we would be talking about 160,000 items of mail that are lost each day. In the banking industry, if a 1% error would create 370,000 errors per hour at ATMs. And with regard to our tax returns, if we had a 1% error, there would be 20 million documents lost by the IRS each year. Now, some people might view that as a positive, but aside from that, what I'm trying to point out is that these would be totally unacceptable rates of error in other industries. So why do we accept 1% or even more than 1% in medicine? This was recognized recently in 2001, about 10 years ago, by the Institute of Medicine's report called Crossing the Quality Chasm. And in that report, I picked out a couple of quotes that I thought were particularly relevant to this discussion, which is between the healthcare we have and the healthcare we could have lies not just a gap, but a chasm. And so we have to do whatever we can to cross that chasm. In its current form, habits, and environment, American healthcare is incapable of providing the public with the quality healthcare it expects and deserves. So we have a long way to go. And even though this report is 10 years old and we have made some progress, there's still much progress to be made. Now, there are a variety of approaches to patient safety. We're going to talk about some of them today, but not all of them. I listed some extra ones here just for you to think about. First of all, there's the role of health information technology and how that can improve patient safety. For example, the use of computerized provider order entry, or CPOE. For example, if you have computerized order entry, then one is unable to enter, for example, the wrong dosage of a medication because the computer won't let you do it, and that will improve your patient safety. A second example is clinical decision support, CDS. This is when you have a computerized system and you go to put the patient on penicillin, for example, and because the information is already entered into the system that that particular patient is allergic to penicillin, then you end up having an alert box that comes up and says, you cannot prescribe penicillin to this patient because this patient has a penicillin allergy. Or clinical decision support could be a reminder telling you it's time for the patient's immunizations in your office or something of that nature. So that's another way of preventing errors from occurring. The third example I gave in information technology are the electronic health record or personal health record. These are not so relevant to neonatology per se, but in pediatrics and adult medicine, they're very relevant because very often when patients present to a doctor's office or to a hospital setting, we don't know much about them. If everybody had a complete record of every hospitalization they had, of every visit they had to the doctor, then we wouldn't have to try to get this information over and over again. We wouldn't have to rely on the patient's memory to supply this information. And we have a long way to go before our electronic systems can all talk to one another and allow this type of interoperability to occur. Now, moving away from the information technology, benchmarking is something we will talk about in our presentation later on today, is something that's extremely important in the use and its use in improving patient safety efforts. What this means is that you have to compare your results in your nursery or in your hospital or in your unit to other units around the country of a similar type. This will give you an indication of how well you are doing, what is the quality of care that you're actually providing. And without that information, you really are shooting in the dark. You may think you're doing a very good job, and when in fact you are not. And you may not be, you may be thinking that you're not doing a particularly good job, but when you compare it to everybody else, you have comparable results. Reporting strategies, I'm sorry, I skipped one. QI improvement initiatives, obviously very important, and that's what we're going to talk about a little bit more later in the lecture, what you can do, what type of efforts can be made to improve safety with regard to particular processes of practice. Reporting strategies can also play a major role in patient safety. In other words, how are errors reported? And I think that hospitals in general are developing better systems, and I think that people like yourselves who are in training need to learn this from the very beginning of your practice, that this is not something that's punitive, but it's something that's very important for us to report our errors so that we can actually learn from them. They should be learning experiences. They shouldn't be blame games. And we'll talk a little bit more about that as well. And then overarching all of this, there has to be a major commitment on the part of your institution to patient safety so that all of these things can be put in place and all of these things will work together to make the hospital a safer place. Now, going back into the history of patient safety, this is in fact not a new issue by any means. Interestingly, it started in the nursing profession before it came to medicine. And Florence Nightingale is considered one of the forerunners of patient safety in that in the 1850s, in the 19th century, she used statistical methods to show the effects of unsanitary conditions in military hospitals and how those led to a higher infection rate. So she was way ahead of the curve compared to many others. Moving a little bit later to the 20th century, in the 1920s, this gentleman, Dr. Ernest Codman, was instrumental in advocating that hospitals and doctors track their practices and evaluate the outcomes of their patients. And actually his efforts helped to found the American College of Surgeons and the Joint Commission, which really oversees how hospitals function and has a lot to say about patient safety efforts even today. These two gentlemen are pretty well known in the more modern era. Lucian Leape and Don Berwick started writing about patient safety issues in the 1980s, and that has led to many projects, including the formation for the Agency for Health-Related Quality, and that they helped form. And Donald Berwick, for those of you who don't know, he became and is currently the head of CMS, which is Medicare and Medicaid. And this was something that I think one of the main reasons that President Obama appointed him is because he's such a maverick with regard to patient safety efforts. And in 2005, they formed this AHRQ, which I think I misspoke before. It's the Agency for Healthcare Research and Quality. And they proposed a very aggressive agenda for patient safety goals by 2010. I don't know that all of their goals have been met, but at least they have an agenda moving forward. Here's another leader in the area of patient safety in this modern era, our current era. This is Peter Pronovost. He's an intensivist at Johns Hopkins Hospital in Baltimore. And he's done many patient safety studies, but one of his most notable ones was something called the Keystone Initiative. I'm not sure why it was called that, since I live in the Keystone State of Pennsylvania, but the study was done in the state of Michigan. And what was done was they took 103 intensive care units around Michigan, and they put initiatives into place to reduce the incidence of central line associated bloodstream infections. This was a highly successful project. They reduced the incidence from 7.7 to 1.4 infections per 1,000 line days using this evidence-based intervention that they created, which included very simple things like people washing their hands before they placed central lines, that they used full barriers, in other words, glove, gown, and mask, before they put the line in, that chlorhexidine was used to cleanse the skin of these patients. They avoided the femoral site. And probably one of the most important aspects of this, and something that we can all learn from, is that they talked about removing unnecessary catheters every day. So in other words, when they made rounds on the patients, if the patient still had a central line, somebody on the team brought up the issue every day: does the patient still need this catheter? And by removing the catheters when they were no longer needed, they were able to reduce the incidence of infection. We're going to talk to you a little bit later in the lecture today about a similar study that we did in our neonatal intensive care unit. One of my personal heroes in the patient safety movement is Atul Gawande. And he is a surgeon at Harvard, and he wrote the Checklist Manifesto amongst many other writings on the subject of patient safety. The Checklist Manifesto, if you haven't read it, I highly recommend it. It's a rather short book to read and a quick read, but a very important one, in which he describes how the World Health Organization asked him to develop a checklist to be used in operating rooms around the world. So in other words, this checklist could be used in the operating rooms in Harvard where he practices, or in the middle of the bush somewhere in Africa, and would be applicable to any of those settings or anything in between. And he, in searching out how to do this, what he did was he visited and learned from people in other industries about how they create checklists and how they use them within their industry, like the airline industry, like the building industry when skyscrapers are built, for example. And I have this quotation here that I'll read to you from the book, which says, "It's common to misconceive how checklists function in complex lines of work. They're not meant to be comprehensive how-to guides, whether for building a skyscraper or getting a plane out of trouble. They are quick and simple tools aimed to buttress the skills of expert professionals." And by remaining swift and usable and resolutely modest, they save thousands upon thousands of lives. So think about that plane that had to land in the Hudson River a few years ago. Would that pilot and co-pilot and the entire crew of that plane been able to do what they did and bring all those people to safety if they weren't following a checklist along the way? I doubt it very much. Now, some people, when I've given this lecture before, have taken a little bit of, well, they were a little bit taken aback by the title of this slide, that not all safety studies are rocket science. Now, what I mean is that very often you can use very simple interventions to improve patient safety. So compared to studying the molecular mechanisms of a certain disease, using a very simple methodology, you can improve safety for patients. And I'll give you an example of that. A study published by Luby in 2005 was on the use of soap and promoting hand washing to squatter settlements in Pakistan. And they were able to demonstrate in a very rapid fashion a decreased incidence in pneumonia, in impetigo, and in diarrheal illnesses. So it had a dramatic effect. So let's talk now about the model for improvement. How do we go about this? Well, the model is simple but powerful, and it's meant to work in a very rapid sequence. It is made up of two components, which we will review. The first component are three very fundamental questions. What are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in improvement? The second part of this tool, of this model, is the plan, do, study, act cycle. And that is what we use to test and implement the changes that we've made. And you also have to assemble the right team to work with. And what I've found in my experience in patient safety is the more disciplines you have involved, the better off you are, because you get all different perspectives. Now, that doesn't mean that you should have a committee of 100 people, because there is what's called a two-pizza rule in forming a team, and that is if you can't feed the team with 2 pizzas, then the team is probably too big. So you want to assemble the right team, and you want the team to be the right size. So the first part is, what are we trying to accomplish? First of all, that means, what are our aims? Our aims should be time-specific. They need to be measurable. We need to see the effects before and after the intervention. And we need to define a specific population in which we're going to make this change. What I also mentioned here is that the Institute of Medicine, in that document that I mentioned earlier, Crossing the Quality Chasm, outlines 6 aims for improvement, overall aims for improvement, that care should be more safe, more effective, more patient-centered, it should be timely, it should be efficient, and it should be equitable. The second part is, how will we know that a change is an improvement? And that means we have to establish the right types of measures, the right types of things that we're going to track. So these are quantitative measures, and they need to be determine if a specific change leads to improvement. And one of the forefathers of the safety movement was Donabedian, and he wrote articles a number of years ago describing the different types of measures. And these can be measures in structure. So that would be something like, how many nurses do you have working in your unit? Process measures, how do you go about administering antibiotics? And how does the antibiotic come up from the pharmacy, and so on and so forth? Is it unit dose, or Does somebody else in the unit have to measure it out? That's just an example of a process. And then outcomes measures. And outcomes measures are, mortality or certain specific morbidities. So those are the three different types of measures you can choose to measure. Outcomes are the hardest ones to measure. So it might, behoove you, if you're going to do one of these studies, to start off with something that's either a structure or a process measure. And then what changes can we make that will result in improvement? So there's a quote in patient safety circles that while improvement requires change, not all changes lead to improvement. So specific types of changes that you might want to look at would be something like eliminating waste in a process. So in other words, that would reduce costs, improving workflow, optimizing inventory, changing the work environment, changing how providers and customers interface. Time management issues are also could be an area that you could look at. Focusing on variation within a process, which we're going to talk about in a little bit. Error proofing a process, and focusing on outcomes. So these are all the different areas of changes that you can look at. Now the next part is the plan, do, study, act cycle. During the planning phase, you decide what test or observation you're going to make. You start data collection and you make a prediction about which way things might go in your study. In the do stage, you administer the test and you document any problems and you continue collecting data. In the study part, you analyze the data that you've collected and you compare that to the predictions that you made initially, and then you summarize and reflect on it. And then act. And act is the stage where you refine the change, because you may not have thought of all the things, and you'll see how some of the studies I'm going to present to you in a little bit, we went through a couple of different phases in our thinking and added additional things in that we thought could then improve the safety efforts even more. So you make modifications and then you plan the next test, so you start the cycle all over again. So now, when I've given this lecture before, what I'd like to do is have you take a couple of minutes to talk to one of the other people in the audience here, or for those of you watching this on NICU University, you can just pause the presentation at this point, and I want you to think for a few minutes, just come up with one idea about how you might improve patient safety in your part of the hospital. Now that we've had that little interlude, I will suggest to you, although those of you watching this on NICU University can't give me your ideas, when I've done this before, I've found a whole host of ideas that have come out of the audience and suggestions, very simple things, and it's not difficult to put these things into motion. So it's something that you should sit around and think about with the other people in your area of the hospital. What can we do to make this area safer? Now, in order to talk about the next studies that we're going to present, I need to give you a little bit of information about something called process control. Now, process control recognizes the fact that individual measurements from any process do exhibit variation, okay? And I'll show you what I mean by that. There's data that there's something called common cause process variability, and that is predictable and within a certain range. So for example, if I were to measure the temperature in this room on certain days, then we would see a certain amount of normal variation, normal fluctuation in temperature of this room. That is just not due to anything more than the fact that, the temperature outside is a little bit different or what have you. So there are going to be normal fluctuations in that. But then there are special causes. So for example, let's say today that this room, that the heat broke down in our building where we're giving this talk, and all of a sudden the temperature in the room went way down. It got very cold because the heat wasn't working. So that would be a special cause as opposed to common cause variability. And so using the data when you're measuring a process will allow you to establish statistical limits, and you'll be able to test your data and see if they deviate from predictions, and it'll provide statistical evidence in a very rapid way of any change. These control charts that are generated from this process control is a simple statistical methodology which can be used to distinguish between the common cause and the special cause variation. So there are two basic parts to this type of methodology. There's a series of measurements that are plotted over time, and there's a template which I'll show you that consists of 3 horizontal lines. One is the central line, and then there's the upper control limit and the lower control limit. Okay? And these values are established from the inherent variation in the data. The data that fall outside those 2 control limits are indicators of special cause variation rather than common cause variation. So here's an example of a process control chart, and you see the thick line that runs right down the center is your central line. The dotted lines above and below that represent the standard deviations, and the upper control limit is the heavy bar at the top. The lower control limit is the lower bar at the top. And this shows different configurations. For example, if you have one single point outside the control limit, that may not be an indication that there's a problem. For example, due to special cause, it may just be a blip. So you have to see some consistency. You have to see 2 or 3 points that are outside a control limit before you start considering that there really is some special cause variation. But in the middle there, what you see is 6 consecutive points that are increasing, or they could have been decreasing. So there's a trend, and that trend also may indicate that you're heading towards some special cause variation as opposed to some common cause variation. When all of the points are clustered as they are there on the right side of your screen around the central line, that pretty much means that the process is within control. The benefits of this methodology is that they are very useful in the daily management of healthcare processes. It gives you a visual picture of what's going on, and I think everybody can understand quite readily, and you'll see when I show you some of our results that it's very, very easy to understand. It combines the rigor of classical statistical analysis with time sensitivity of a more pragmatic approach to improvement. And it reduces management of processes by opinion. So in other words, you can't say, oh, well, we're doing better than most other people. But if you plot it a long time and you look at the variability, you'll see, are you really doing better than other people or not? It avoids waste from making changes that just sound good, and it helps you decide on the correct improvement strategy that you want for the particular process that you're looking at. Now, the gold standard in research has always been the randomized controlled trial, and it still is for many good reasons. However, some people bring up some of the pitfalls of it and why process control may have certain advantages compared to it. So there are ethical considerations because in randomized controlled trials, half the group is getting the intervention, whereas the other half is not. And when you do a process control, everybody is getting the same set of interventions. There are problems with randomization. You may not get a good randomization, and therefore the 2 groups may not be equivalent at the outset, whereas in process control, you don't have to worry about that. Randomized control trials are very expensive, especially compared to the process control approach, and they're time consuming. Also, they may not be generalizable, which means that if you do it within your particular hospital, in your particular setting, you may or may not be able to apply that to somebody else's hospital or to their setting. So we're going to start now showing you some of the studies that we did. And this study was done by one of our neonatology fellows in our program at Jefferson. And her name is Haritha Valanki, so she deserves the credit for this. And what she noticed when she looked at our benchmarking data from the Vermont-Oxford network. The Vermont-Oxford network is a network of many, many neonatal units all over the United States, and actually there are international NICUs involved as well. And it's every 6 months, units that participate, that means that you send them your data about your outcomes, get data back, like this that we're seeing in this graph. So the black line is a relative ratio or a risk ratio of 1, which means that you're the same as the group. And so if your bars above and below your the black dots, which are the 95% confidence interval limits, if that crosses the line of 1, then that means that you're within the norm for that particular parameter. If, on the other hand, it's below, that means that you're better. And if it's above, it means that you're worse, that your unit has a higher relative risk of this particular problem. So if you look at the far left-hand side of the graph in front of you now, and I know that the things that are written along the bottom are rather small print, but the one on the far left, which is clearly above the number 1, and both, as far as the confidence limits go, that's pneumothorax. And through this data, we found that we had a problem with pneumothorax in our unit. Now, we never would have known it, really, if we hadn't been benchmarking, because you have to realize pneumothorax is a relatively rare occurrence. So whether you really have a higher incidence or a lower incidence compared to everybody else, you wouldn't really know. But this data told us that we had a problem. And so Dr. Valanki assembled a team to try to address this concern. During the first phase, she enrolled infants less than 1,500 grams at birth and followed them prospectively for 6 months without any new interventions regarding pneumothorax. She, in this way, established the baseline incidence of pneumothorax, and she plotted this on a process control chart for that 6-month period. They did a root cause analysis to try to figure out what was the cause of the pneumothorax. They looked at every aspect of it. They looked at management within the delivery room. They looked at management after the baby was admitted to the NICU. And what they found was that babies' ventilation settings were not what they needed to be when the baby was first placed on mechanical ventilation. So they came up with this template that you see in front of you now, that whether the baby was going to be on time cycle pressure limited ventilation or volume targeted ventilation, both of those modalities are used within our NICU. There would be guidelines, that, for example, the tidal volume would be somewhere between 4 and 6 mLs per kilo, or that the peak inspiratory pressure that was ordered would yield between 4 and 6 mLs per kilo of tidal volume. And there was a huge education effort within the NICU. So this involved nurses, it involved nurse practitioners, it involved fellows, it involved residents, it involved respiratory therapists. And these guidelines were placed all around the unit and hanging off of each ventilator. So if the initial settings that a baby was placed on the ventilator did not meet these criteria, then the respiratory therapist or the nurse were charged with informing the physician or the nurse practitioner that we were not following the prescribed guidelines. They also, to make things simple for everybody working in the unit, they developed this little table that simply, based on the baby's weight, calculated what the tidal volume should be. And these were also hung off of all the ventilators that used in the nursery. During the second phase of the study, the methodology that I just described, the protocol was implemented for another 6 months, and then the control charts were plotted and analyzed to see if there was a variation in the process. And here's what happened. Okay, we started out high, all the way over there on the left. It's interesting. I think there was a bit of a Hawthorne effect here in that we can see, because as soon as we started tracking this, you can see that the number of babies with pneumothoraces came down to within the limits between the upper and the lower limit. And that's a very common thing in studies. Once you start to study something and people know that you're studying it, then sometimes the problem improves already even before you start your intervention. What it shows here is the black line right down the middle is where the intervention started. And then as we go to the right side of the chart, you can see where the red dots are is where we started to reach statistical significance in improvement of the project. So that means that things were getting better. And you can see that there's a red dot on the far left as well, and that was an indication that at that point we were outside the control limits, and that was significant, and now we were significantly below. So we brought this process under good control with the methodology I just described. And another way of looking at this, more standard statistical analysis of the results, you can see that there were, in each phase or epoch of the study, the pre-intervention, there were 82 patients without pneumothorax in pre-intervention and 12 that did have pneumothorax for a 12.7% incidence. And then afterwards, there were 2 pneumothoraces and there were 82 patients without. And this gave a percent of 2.3%, and comparing the before and after gives you a p-value of 0.01. So this was a highly statistical significant result, a relatively simple intervention, and we continue to use this practice to this day to make sure that babies are getting the right amount of ventilation. So they concluded that increased vigilance and monitoring of tidal volumes during the first 2 days of a baby's life decreased the incidence of pneumothorax in our population of very low birth weight infants. Here's another study that I was involved in along with my colleagues listed here. We did a performance improvement project to try to reduce the incidence of infections from peripheral long lines or PICC lines in preterm infants. They're used, as you know, for all of you working in the NICU, they're used quite often nowadays, and the reason for that is that they're easy to insert, relatively easy to insert. They stay in for a long time, and there's a perception that there's a low infection rate. But we discovered, again, through benchmarking our data internally for this particular instance, not by the Vermont-Oxford data, but comparing it to the infection rate of other lines like umbilical venous lines and central venous lines, and looking at some external data for benchmarking rates, we found that our infection rate for peripheral long lines was actually quite high. So the study was approved by the IRB, which is an important step that we must do, and then peripheral long line CABCs, we call them, catheter-associated bloodstream infections, since they were not all central. Not all the PICC lines were central, so we didn't put that part in. But the CAPCs were defined as a primary bloodstream infection in a patient that had a line in within 48 hours before the development of the bloodstream infection. And we assembled a multidisciplinary team, which included a neonatologist, a neonatal fellow, a nurse practitioner, a staff nurse, an educator, and a clinical specialist. We utilized the input from an infectious disease physician, as well as an infection prevention nurse, and then a performance improvement facilitator that works with our team. Now, when you review the pathophysiology of infections from central lines, you find that along the continuum of where your line is, there are a number of different potential targets for where infection can be introduced, and thus where prevention can help. So it can be related to the infusates or the drugs themselves. It can be related to the hub where things are connected. It can be related to the dressing. It can be related to the skin. It can be related to the catheter itself, or it can be due to hematogenous spread. In the first stage of our study, we developed a PICC line team. We had providers who were credentialed based on their skill level and experience, and we had a core group of 2 nurse practitioners and 2 NICU nurses and 4 nurse practitioners who placed PICC lines. I will tell you that we had to do this within the context of a teaching program, and we still have ways that fellows can learn to do this procedure for those of you who are listening to this and might be concerned about that. So we still used, still had fellows putting in lines, but they were supervised by this core group. And then the lines, once they were placed, they were also maintained by this core group. We also made standardized dressing changes. So the initial skin preparation was with povidone iodine, and then the initial dressing was a transparent covering over a gauze. It was changed after 24 hours, and the subsequent dressing, the site was cleaned with alcohol and covered by just a transparent covering every 7 days. And all dressing changes were done by the same core team. During a second stage, after we successfully reduced the incidence of infection, and I'll show you the results in a moment, we wanted to do even better. And so we created a second intervention stage, which involved when they cleaned the hub, they put on sterile gloves and they used an alcohol wipe. It was applied clockwise and counterclockwise around the hub 3 times each way. And then we also created standards for changing over the fluids and the tubing. So we added the addition of a sterile field. In other words, when the nurses changed over the hyperal that was going in through these lines every 24 hours, they created a little sterile field with a sterile towel. They put on gowns, gloves, and masks when they were changing over the fluids. And this involved, development of a whole new clinical practice guideline for the nurses and a huge effort in NICU nurse education to do this. And we had to, as always, monitor for compliance with the approach. So the study ran from 2005 to 2010. During that time, we had 1,180 admissions that were less than 1,500 grams. We have a very busy nursery, as you might guess. We had, during that period, 311 peripheral long lines, and we had 18 peripheral long line catheter-associated bloodstream infections. During the baseline period seen in the top row, there were 11 infections out of 1,063 line days, or an incidence of 10.3 infections per 1,000 line days. And that's a standard way of reporting line infections in all studies. During the first stage, where we had the first set of interventions, we had 5 infections out of 15 line days, or an incidence of 3.8 infections per 1,000 line days. This was an incidence rate ratio of 2.7. That's how much we were able to reduce it by, and this was statistically significant, from 10 down to a little bit less than 4 at the 0.05 level. During the second stage of the study, with the second stage of interventions, we had only 2 infections out of 1391 line days, or an incidence of 1.4 infections per 1,000 line days. This was highly significant with a p-value of 0.003. So what we did was we reduced overall, with the 2 phases of this study, the infection rate from 10 infections per 1,000 line days down to 1.4. This is a dramatic result, something on the order of magnitude of Pronavos study that I quoted you, the Keystone Initiative, back at the beginning. I believe they started at 7.7 and came down to a range similar to what we had, about 1.7 or something along those lines. So the conclusions of this particular study, this is the second study I'm telling you about today, is that use of a dedicated team for the insertion and maintenance of peripheral long lines, along with standard dressing changes, led to a 63% reduction in peripheral long line, central line associated bloodstream infections. Addition of a sterile field and a modified nursing clinical practice guideline for changing over the fluids led to an 86% reduction from baseline in the incidence of peripheral long line associated bloodstream infections. But we're not stopping here. We're trying to do continual improvement, and we're trying to think of new strategies. And I think that's important because much like we used to accept the rate of infection that we had initially, and that's what led to that complacency, is what led to us having a pretty high rate. We shouldn't be complacent with the 1.4. We need to really have a zero tolerance and try to create new strategies to bring the rate of infection down even farther. So performance improvement is ongoing, as I said, with a goal of zero tolerance. Further additions to the process that we have planned. There's a new scrub cap that's available to scrub the hubs of our lines, and we're going to think about using those. We're thinking about changing to a mechanical valve interface between the peripheral long line hub and the IV connection. We're considering the use of chlorhexidine as our skin preparation. Even though it's been shown to be effective, it's currently not recommended for babies less than a certain gestational age, and I believe that number is about 28 weeks gestation. And we plan on adopting the interventions that we did for long lines for all types of lines, including central lines and umbilical catheters, etc., in terms of the things that we did in this study. The last study that I'd like to present to you this morning is a study that we did to prevent delivery room associated hypothermia. And this study was named the Cozy Cuties Project. Again, through benchmarking, we were able to see that we had a problem with our admission temperature in our babies. And this is a graph of the admission temperatures of the babies in our unit that were less than or equal to 30 weeks. And you can see, if you add them all together, the first 3 bars on the left-hand side, that 54% of our babies came in with an admission temperature of less than 36 degrees centigrade. Again, here's data from the Vermont-Oxford network for our nursery compared to all other nurseries. The bars that you see on the bottom are the 95th percentile confidence intervals for admission temperature less than 36 from the entire network. So those bars represent all the other nurseries, composite of all those other nurseries. The yellow dots above them represent our institution. So overall, every year for that 5-year period, we had a higher rate of admission hypothermia than the nurseries in the Vermont-Oxford network. This, again, this benchmark data is what alerted us to the problem. Now, why is this important? Because for each degree centigrade that your admission temperature is lower in a premature baby, the chances of survival are also decreased by about 10%. And interestingly, for each degree centigrade decrease in admission temperature, there's a higher incidence of late onset sepsis as well. And that study also confirmed that there was an increased odds ratio for death. So this is pretty important. When we realized we had a problem, we again formed a multi-specialty group that involved multidisciplinary group that involved a neonatologist, a neonatal fellow, a doctor of nursing who's a research facilitator. We had nurses, nurse educators involved. We had a committee of about, I would say about 10 people altogether. So well within the pizza rule. And we started to ask a number of questions. What was the room temperature where the baby was being delivered? Were we warming the radiant warmer ahead of time before the baby was born? Were we using polyethylene wrap in an appropriate fashion to keep the babies warm? Were we warming our hands that we were then touching the baby with? Were we blocking the overhead heater with our bodies as we were leaning over the baby? How and when were we weighing the baby? Were there vents or cross drafts in the rooms where we were resuscitating the babies? And are we warming the next microenvironment where the baby was going to be placed, in other words, into the transport incubator? Were we warming that up appropriately? And here's a run chart for our temperatures. And I think that what you can see is that, again, on the top graph going from the left to the right, that the temperatures were lower and then they start to come up higher. And the opposite, the one on the bottom, is actually for each 10 patients over time, and when we started to see a decrease in the incidence of the rate of low admission temperature over time. So this was a highly successful effort, and we went from 54% down to initially about 13% in our rate of admission hypothermia, and we have rebounded back a little bit to about 20%, but we're keeping constant vigilance and we're developing new methods to try to keep the babies warm. So we have a whole different new methodology, which I did not go into detail to explain, but we have raised the temperatures in the delivery room, for example. We now go to the bedside and have the baby handed to us directly so that the baby doesn't spend too much time at the point of delivery. We pre-warm the radiant warmers. We have a special method for wrapping the baby in the polyethylene wrap, and that altogether has had a dramatic effect. So I think I didn't want to go into too much detail of our methodology, but if anybody's interested in our study or our protocol for keeping the babies warm, feel free to drop me an email. I'd be happy to share that with you. So there are 5 stages of grieving when somebody dies, and this is something that somebody else, I can't take credit for this, put together about grieving over outcomes data. During the first stage, which is denial, you say, oh, these data can't be right. We can't be doing that much worse than everybody else. The second stage is anger. Why are they picking on me? Don't I have enough to do already? Do I really have to worry myself about admission temperatures or rates of pneumothorax? Next stage is bargaining. Well, it must be because our patients are sicker than all the other patients in the NICU that we have the results that we have. My NICU is different, and I don't agree with the definitions that we use for the data, et cetera. Then the next to the last stage is depression, which is, I can't do anything about this anyway. It's just, the incidence of pneumothorax is going to be what it is, no matter what we do, and we just have to accept it. But then during the acceptance phase, the final phase, it's okay, what can I do to improve the outcomes in my NICU? And I think this is the stage that we all need to get to, so that we realize we can do something about it and have a very positive attitude about bringing about these changes. We need to function more like what are called in industry highly reliable organizations. These are organizations that are focused on failure. They are preoccupied with the possibility of failure. They're always looking for ways in which failures may occur. They train the workforce to recognize these failures and try to address them. And this is how they create a culture of safety. Very, very important. In medicine, we've generally touted our successes. We need to focus more on our failures and use them as learning experiences. We need to generalize from these failures, not isolate them. In other words, don't say, oh, this just happened one time, it won't happen again. We need to figure out ways to not allow it to happen again. And try to imagine novel scenarios of failure. I mentioned, the airplane that landed in the Hudson River. That crew was able to envision something like that happening because they had sat down as a group repeatedly and gone over various different scenarios of what might have gone wrong, what could possibly go wrong, and what would we do under those circumstances. And we don't do that. We don't sit down and say in the delivery room, what could go wrong? Or in the NICU, what could go wrong? And then you have to rehearse. You have to practice these things over and over again. So that's why we're using a lot of simulation in medicine now, is because people aren't getting the same amount of experience, hands-on experience. But this is what they do within highly reliable organizations. They take their failures, they analyze them, they generalize them, and they use them to learn to prevent the same type of failure from occurring. Very, very important. So what is the future of patient safety, patient care safety? I think we need to think more like astronauts. I heard a very interesting lecture many years ago by a graduate of Jefferson Medical College who went on to become an astronaut in our program, astronaut program in the United States. And he talked about how every single mission, they sit down and have extensive debriefings so that they learn from every experience what went wrong, what went right, what could we do, what could we do better the next time. That was the mindset. Another reason that it's important to do patient safety is because mandates are on their way and they've already started. So there's something called pay for performance, which many of you may not yet be familiar with, but it's already begun in the Medicare program, for example, where the government is not paying for certain things. If a patient gets a hospital-acquired infection, and that requires the patient to stay an extra number of days in the hospital, Medicare is no longer paying for those extra days. So, when you hit people in the pocketbook, they really listen. These mandates are on the way, and that's why we should really think very much about, improving our patient safety so that we can, as hospitals and as practitioners, can remain financially solvent. But the most important reason is that we should improve processes of care and promote patient safety because it's the right thing to do. And we want our patients to do as well as they possibly can. So I thank you for your attention this morning. I enjoyed speaking to you about this subject that means a lot to me. And again, if any of you have any questions or comments, I'd be happy to answer them at this time. And also, for those of you who will be watching this on NICU University, I will give you my email address is sperlman@christianacare.org. And please feel free to drop me an email if you have any questions about any of the safety efforts that I talked about or anything else in this lecture. And I thank you again for your attention.